Any comments on looking at torics versus peripheral relaxing incisions versus femto?
I just have a comment on just, there's many pros and cons to femtosecond laser surgery, but one of the things that I actually really like about it is it makes me think about astigmatism management. Some people will say that they don't like doing manual LRIs or as limbal relaxing incisions as much just because there's a little more variability in terms of the depth, the architecture of the incision, and, I would say that would be one of the pros in my book of greater adoption with the femto.
Are we moving on? We're going to do this panel. Okay, so how many of you guys feel comfortable doing LRIs at the slit lamp or in the office for residual refractive error, and how do you tackle that?
Yeah, I think it's a great technique, and I've seen Eric Donenfeld do that. I remember just early on, I saw he's got the shorter diamond knife, and you can do that right at the slit lamp, and I think that's a great technique, great tool. So I think I think it's definitely worth keeping in mind.
That's the first time I've ever heard Eric called short.
And I just, with respect to that, and not to make fun of Eric here, but I'll move off that topic. But it is important that when you're looking at the pseudophakic state, again, to focus on the refractive astigmatism at this point, not the keratometric astigmatism.
Great point. One other technique, going back to femto versus blade LRI. One consideration I always, I consider is one of the big disadvantages to femto is you're stuck to the preoperative diagnostics to make your decision, and if you're using intraoperative aberrometry, you don't have that ability. You've already really more or less created that femtosecond laser. So I typically do intraoperative aberrometry guided blade LRI. So at that point you can see what the axis is, place a little, how much is there, place an incision, you can enhance that on the table. So it's one other consideration when analyzing those two techniques.
We are so fortunate now that we have a version of a toric lens implant that can treat less than 1 diopter of astigmatism. The Bausch & Lomb lens, the T1.25, can functionally treat corneal astigmatism of approximately 0.8 diopters. So that means you're against the rules that are half a diopter if you're counting the posterior cornea, and you're with the rules maybe 0.91 diopter. Now you can treat that as well. I do think that relaxing incisions and astigmatic keratotomies are wonderful, particularly in the setting of enhancing your patients postoperatively or for that really low sill. But Dr. Rubenstein made such a great point, which is if you're going to be between two toric powers, go ahead and use the lower of the two. It's better to undercorrect than overcorrect in a lot of scenarios, because if you overcorrect and you overcorrect it too much, so now you have a toric lens that is in one position, but their new refractive postoperative astigmatism is the complete opposite. Placing an LRI in that complete opposite axis can actually affect vision for the worst. It becomes a very complicated visual system. So I think that is a really good takeaway, Pearl. If you are doing toric lens implants and you may have to enhancing an undercorrection is a much better option for the patient visually.
I want to echo the comment earlier that with the advent of toric and presbyopia correcting lenses together, I've personally used a lot fewer LRIs, and I did have a femto for a couple years, and basically I almost do none. Now I do almost all of my astigmatism correction through IOLs. Since Eric's sitting down, I'm okay saying that I don't do LRI. He doesn't have a microphone, so I don't do LRIs at the slit lamp. But if I do have to enhance postoperatively, I prefer a laser vision correction approach. I think it gives better accuracy, and at the end of the day, we're talking about astigmatism in the symposium, but refractive error is still a very real issue for us postoperatively.
Can I ask a quick question of the panelists? I'm going to present a really simple scenario. You have 0.7 diopters, axis 30. Would you do phaco and steep axis, relaxing incisions, femto or manual, or would you put a toric lens in? 0.7 axis.
Toric lens.
Toric lens.
Toric.
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 Toric, but I wouldn't fault someone for operating on axis and then making a paired incision 180 degrees away.
Sure. Yeah.
You do it.
That's
what I would do, what she just said.
Yeah. Phaco and steep axis.
With a
relaxing
paired
incision. How many would flip the axis on a 0.7 at 30 to flip it over to patient 65?
I would flip their axis.
I wouldn't mind flipping them because they're probably trending towards against the rule. So it's going to neutralize within the next year or two.
They're already against the rule
Well,
No.
technically, yeah,
at
well, yeah,
30 degrees.
oblique-ish.
Yeah. Okay.
I don't even know.
All right. Thank you very much. Interesting discussion.